Hi everyone, and welcome to this second immunization webinar. We are very happy to have you all, and I hope you have noticed that there is a new format that we are experimenting a little bit. We are streaming live through the community of practice, so the communication will be a little bit different. I hope everyone can hear me. Can people hear me? Because I've been told that people cannot hear me.
I can hear you.
Oh, okay, thank you. So yeah, we are streaming live through the community of practice, which is like a new format that we are checking out. And so we would like you to be involved directly in the community of practice. Please introduce yourself, ask questions, make comments throughout the presentations. And we are going to keep an eye out throughout the whole webinar. We're going to try to answer to your questions. Some of them may be like straight during the webinar. Some others maybe are going to be after the webinar. But please use it and abuse it, really. We are hoping that these conversations are going to be useful for the viewers today. But the most important thing is that they're going to remain in the community of practice, and this way they can be used later on from other people. There is also in the community of practice thread, at the moment, there is also a poll with a few questions. So you are welcome to give us more information about you, your background, and your experience with Tracker and in general DHIS. Today we're going to focus mostly, as you see in the first slide, on the electronic immunization registry and the vital event certification packages. For those who were present in the DHIS annual conference in June, we had already announced that we were launching new packages, and these two were among them. But as summer goes, we were thinking that now that people are coming back from holidays and the summer is over, to revamp a little bit these packages. And so we are going to discuss mostly the electronic immunization registry, but the vital event certification, you will see that it's of primary importance for the data collection and can help a lot, the data collection for the population information, but in general, also to give more information for the routine immunization activities. Today with us, we have some very well-known presenters, but at the same time, probably the most important presenters. So we have Kim Frost, who is like the queen of vaccine. She's our clinical consultant, and she worked very closely with both packages. And she's going to give us an introduction, especially for the electronic immunization registry. And we have Brian O'Donnell, who is our expert of e-registries. And finally, we have Adolphe Kamunga, who is our senior DHIS implementer at DHIS2 Rwanda. So without further ado, I would like to give the microphone to Kim. I cannot hear you.
I did my video, but not my voice. Okay, can you hear me now?
Yes.
Okay, great. Yes, if you could just go to the next slide. Yes, so as Vito has mentioned, we have published our electronic immunization registry. This is the focus of 0 to 18 month immunizations for children. This work has been an ongoing process, and it was actually a foundational starting point for the COVID vaccine work, based on the work that we had previously done with this prior to COVID. We were able to jump in quite easily to make a COVID program. The Immunization E-Registry digital data package was developed in response to an express need from countries and partners to improve timeliness, accuracy of data, coverage, and effectiveness. This program was designed based on the WHO position papers, recommendations for routine immunizations. We also collaborated with institutions such as the Norwegian Institute of Public Health and highlighted country use cases from Zambia, Botswana, and Rwanda, and also literature from PAHO. With this, we were able to use an e-registry approach. An e-registry approach is something that provides clinical guidance to healthcare providers, focusing on immunization schedules, contraindications, and global standards. Rwanda was the first country that we worked with to adopt this package, which they adopted to fit their immunization context last year. It is to note that national guideline and policy may vary and is highly recommended to adapt this package to the local context. And this was what we also found in Rwanda. This is a starting point for countries to have an electronic immunization registry. But it does need to have an implementation process and decision-making process. Next slide. This is the structure and flow of the program that has been created. We have the immunization program. Within that, we have birth details and immunization stage. For many children, the immunization program might be the first entry point into the health system. The EIR showcases how small additions to normal EIR workflow can make big impact on patient longitudinal data and cross-sectional data usage. It also provides an opportunity for clinical guidance and support for healthcare providers. As you can see in this program stage, you have a birth details option and an immunization. The immunization stage is where all of the scheduled vaccines for immunizations reside. And then within that, we were able to add a birth notification stage, some pre-immunization, which helps collaborate with the CRVS system, the civil registration and vital events. There we go. With some simple questions. We have pre-immunization questions that help give some clinical workflow based on guidelines. And then we have routine immunization with hide show rules and an immunization schedule and override. That is a repeatable program that goes on. And we have also added birth details, which is an optional stage, which only needs to be added one time, filled in one time, and it gives some basic information of a patient's birth. So this will help strengthen the longitudinal data of a patient and also give information for cross programs opportunity. Next slide. For example, birth notifications to CRVS. By adding a simple birth notification, some questions, and birth details, we have the opportunity to collaborate with the CRVS system in country to see to help strengthen the registration process and generation of strong population statistics. In many settings, healthcare workers already collect much of the core information that is needed to register a birth or a death. By adding simple birth details to the immunization registry, it strengthens longitudinal patient data. And a birth notification, it creates multiple opportunities to help overcome barriers to ensuring that births are notified to the CRVS system. By adding a few notification questions to the ER system, it could create a cascade response with SMS and email notifications. And then you will get a circular effect of once it's notified within the CRVS system, all that information and data will come back as help for generation of statistics and decision making. Next slide. Click. As you can see, this is within the tracker program. We have the birth details, immunization, and adverse events. We have opened the birth details, and as you can see, there's only a few important components of what the birth was. So if this is your child's first time into the health system, we have an opportunity to grab this information. And this is not to burden the healthcare provider because it's a one-time data entry that takes limited time. Next. And then once the healthcare provider opens the immunization section, you'll notice within this program you have a birth notification, pre-immunization questions. By adding 3 simple birth notification questions, can you confirm that the child has been registered into the national CRVS system? If yes, you will have a drop down that says when was the birth registration done? And then you will have another question, has the birth certificate been delivered to the parents? Within the civil registration system, to obtain a birth certificate and registration, there are many steps that it takes to complete this process. By adding this context into the immunization program, you have multiple chances to catch that child to make sure they complete registration. By answering these questions, it will trigger notifications to the CRVS program and possibly to the parents as if it's designed that way. And it is important to note that the civil registration process is a legal process, and it is important to collaborate with the CRVS system to decide what is legally an opportunity and okay to have pushed down to the healthcare provider. A birth notification is just a simple, go ahead, go to the next slide. Birth notification is as simple as this. A birth notification for has been completed at this org unit. Please review the birth details and from the immunization program. This is the beginning of a cascade of notification that can be done by healthcare providers without legal standing. But it is important to make sure you talk with your CRVS system and have a collaborated effort to know what can be done in country. And there are multiple ways to do this. Next slide. So what we just talked about really highlights how simple additions to the immunization program registry can strengthen cross-program data and data programs. We also, using the e-registry modality, we have tried to provide clinical guidance and support to healthcare providers. We have highlighted a few of these avenues. We use DHIS2 program rules. We use warning and contraindications. We use SMS notifications, vaccine card view to mimic the typical yellow card that parents are given. It was very important to healthcare providers to have working lists to help them know who has been in the program, who is coming, and who has been missed. Also, a strong focus on analytics and indicators. If you could go to the next slide. For example, we're back into the tracker program. If you could hit next. Program rules have been entered into the program based on age to help healthcare providers not to be overwhelmed by all the different options. You'll see that the child is currently 2 days old, and hit the next slide, please, is currently 2 days old. So we have some program rules. A child with less than 6 weeks, you should get these 3 different vaccines. So you will see that for BCG, it says show at date of birth and hide once given, or if child is greater than 12 months. And for OPV, show at the date of birth, hide once given, hide when OPV 1 dose shows at 6 weeks. So as you can see, there are these program rules that have been integrated to help strengthen decision-making process and to make sure that the child has received it, and it will show up again in the next visit if it hasn't been given. So it will show up until it's been given or until that child ages out. Next. We have also added warning and validation rules based on the WHO proposition papers. As you can see, we added a few pre-immunization questions, which then trigger warning and validation rules. So as you can see that this child is 6 weeks old, has not received any of his or her vaccinations. So, and that shows that this child is HIV positive, but not on ART yet. So with that, we have BCG. It comes up saying it is contraindicated to give BCG vaccine if the child is HIV positive and not on ART. We wanted to make sure that we didn't hide the BCG totally, because we still wanted to give healthcare providers an opportunity to make their own clinical decision with some valid information. So the healthcare provider has an option at this time to make their own choice. Do they agree with the warnings? Yes or no. They also have a hide show warning for if the child is very sick or has a high temperature. And this one's a little bit less severe. It says, be aware it is advisable to defer vaccine until after acute infection with temperature greater than 39 degrees. So these are some of the rules that have been put in to help decision support. Next. It's been everyone is used to the yellow card, and by just turning on tabular data entry within the DHIS2 tracker program, we were able to get something that mimics the yellow card. You can see what has been given at what time, and you can also click on one of those vaccine events, and it can pull up to show in further detail, which people have really liked this view. Next. Let me see what this question is. And there are no dumb questions. From Derek. I'm sorry, but if a child is registered to the CRVS and a unique ID is assigned by the national authority, is the ID persistent across all programs, including the immunization program, as a golden thread for this child? Brian will be giving a demonstration, and maybe you can highlight this more, but there is an opportunity when you enter a child, you have an opportunity to have either a national ID entered or a unique system ID entered. So that is what we are hoping to create, is a persistent golden thread for this child. Either if it's being, depending on the country, if they don't have national IDs, which many don't, they have the opportunity to use the system-generated ID, which can be used within the DHIS2 programs, across programs. And that could also, if based on country interest, you could also use the national ID. Hopefully that answers your question. We might be able to get into that more with the demo. Working list has been a big, has been something very important for healthcare providers as we have talked to people and talked to healthcare providers about what they need in their immunization programs. So this, within this program, we've scripted these different working events. So you can choose, you can see all current immunization, all current immunized patients, scheduled appointments for this week, scheduled appointments today, and missed appointments, which hopefully can be very beneficial for planning. Next. Within the immunization program, we also have SMS notifications pre-configured. They can be changed as needed, but for an example, this immunization will be sent to parents to remind them of the next immunization visit. And it just something simple says, we want to remind you of your next immunization appointment for this child is scheduled at this clinic on this date. We look forward to seeing you then. Please remember to bring your immunization card. And you have the opportunity to decide when to send this, 2 days before the immunization appointment, 24 hours before the immunization appointment. So all of these things can be configured per country needs. Next. And I just wanted to highlight that our digital data packages are optimized for Android data collection and are in the DHIS2 capture app, and there you can find them at the Google Play Store. So Android is our offline solution. And I've been really impressed what Android has been able to do to be able to do this data entry offline, and then once you have connection to be able to upload the information. Next. One of the most interesting things. Okay, we have a question. Is this tracker to be used at point of care? I will say that it was designed to be used at point of care. However, we know that many countries are not ready for point of care. So this can be done, so you can have data entry clerks do this also. You can choose when that you upload the data. We just wanted to highlight the strengths of what a point of care e-registry tracker program can do. But it can be used in different ways as your country needs. EPI tracker analytics and indicators. I think this is something that's very interesting when you start using a tracker program. With the ability to have individual level data, it enables the capture and analysis of highly granular data and adds nuance to information systems. It provides opportunities for ad hoc analytics and shifting indicators over time. So one of the interesting things you can do with indicators from Tracker is to create cohorts rather than raw data counts. So you can make it more individualized to what your context is. For example, you can have if you want to see all the children that were vaccinated from 6 months, it will look at the child's birth date, if they had it before. So there's different ways that you can look at tracker cohorts and analyze the data, which Brian will highlight a little bit more. The indicators within this tracker program have been based on the WHO EPI aggregate program, which probably many of you are familiar with and maybe have even downloaded into your country's system. So we took the foundational pieces of that EPI aggregate program and created 5 dashboards into the metadata packages, broken down into rollout, age ranges, dropout, vaccine doses, and an overall immunization package. From this, go ahead and do the next slide. We will let Brian take over and give a demo and highlight some of the use cases from the tracker program. Thank you.
Hi, everyone. Can you hear me? Hope everybody can hear me. Yeah. So my name is Brian O'Donnell. I'm going to be doing a short video demo of the Immunization Registry. Just so that nothing goes wrong, I've recorded this, but you can access this the same demo at who-demo.dhis2.org/EIR. And you can log into the demo system and explore yourself as well. So I'm just going to press play here and narrate as we walk through. So as Kim was mentioning, we have, if you go to Tracker Capture app and we select the Immunization Registry program, then we go to our org unit and select a CHW unit. We have a number of different working lists that would provide information on the patients that are available for the next doses. And I can select a patient from there, register a new one. If I register a new one, you'd note that there was a list of previous patients there. So I'm just going to try to generate a new client that's the same name as one of those previous clients and see what happens. So for example, if I say that this name is Gilbert and then enter in some additional mandatory attributes such as patient's contact name, or primary contact's first name and primary contact's last name, then I try to enroll this patient, then I get a pop-up box that says there's possible duplicates for a previous patient called Gilbert. So if that's one blocker to prevent unnecessary duplication of data. However, if I replace this name with Gilbert and last name Sullivan, then this will actually allow me to proceed because there's no primary blockers there. Okay, so now I've opened up a new patient record for Gilbert Sullivan. It's an enrollment in the Electronic Immunization Registry program. You can see that all of the attribute details are on the right, and the birth details and immunization stage are down here in tabular data entry widget. So I will be using some backdates just to showcase some of the functionality that are available. So in the birth details stage, if I enter a birth weight that is too high or too low, then I will get some validation alerts that this is an incorrect data value. Same goes for the gestational age. To improve data quality, it should be in the right range. So then I would select on the birth type, attendant at birth. If the place of birth was at home, then providing more granular detail on what the location was as a village, and then the mode of delivery. Once I complete this stage, then we can move on to the immunization section or immunization stage. So the date of services that we're given will actually give us as shortly after birth. So we remember that the birth date is 15th of June. So if we do the 23rd or the 28th of June here, this is before 2 weeks have passed. And we see the different sections that are available for us. We see immunization routine is BCG 0.5, BOPV, and Hep B. When we say no, the CRS system has not been notified because it's just been night after birth. Vaccination place facility, there's been no history of anaphylactic reaction. We see that the allergies no pops up at the top, as well as the age at visit and current days. Then if we say diagnosed with HIV or severe immunodeficiency, this is alerted to be a high risk at the very top. So in future events, we can also see that this child is HIV positive. There is no recent infection, and now we enter in all of the immunization details such as BCG 0.5 and Hep B1. I'm going to leave these schedule overrides for subsequent visit. So let's now generate a new event here. This is with the plus button there. And I'm going to change the date to be about 7 weeks after birth. And once we do that, then we can see which immunizations pop up. So there's the birth card that Kim mentioned earlier, the yellow card. We can see which immunizations were given in the previous visit, as well as which vaccinations are still awaiting within the schedule. So based on the screen, sometimes I have to scroll a bit. So the date of service is given. Now we're actually going to say, yes, the CRVS system has been notified, and we will be entering the birth registration date there. And now if we also say, no, that this birth certificate has not been delivered, now we can actually get two different program notifications that are showing up under messages, which I will be showing you later. So under pre-immunization questions, we can see that a history of reactions was carried over from the previous stage, as well as HIV status. So we don't need to check off that box. But below that, actually, there's another one which will not be carried over, which is recent infection with a temperature above 39 degrees. So this time we will actually check off as yes. And here we can see the contraindication that's brought up in real time for PCV1. So based on the previous answer under immunization routine, we can say that yes, the child should receive VOPV1 as well as Penta1, and will not be receiving PCV1 because of this contraindication. So then once we say no, we give the reason not given, stock out, contraindication, guardian refusal, etc. We say contraindication. But we also say RV1 rotarix was also given. So let's say that there's some other immunizations that could be given for some reason, such as there's been a recent yellow fever outbreak and we want to immunize as many people as possible for yellow fever. So we would click show non-routine immunization doses here, and we would provide a reason or an explanation. And this then unlocks all of the possible non-routine immunizations that are available to register in the system. And we see that we also mark the date in which the non-routine immunizations were unlocked so that future users could actually look up which was given. So we can check off yellow fever 1 there. But there's a long list of non-routine immunizations that you can pick from. And you can also break the schedule as well by clicking show all scheduled vaccinations in case maybe you missed something or you've given something out of schedule. So now we're going to schedule a new event, and we'll just, to show off the working list functionality, we'll make that event today. So we'll say September 8th and save that. And now we can see the working list was also updated with the previous doses that were given. Now when we go to all current patients, we can see Gilbert Sullivan there, and Gilbert Sullivan is also under the scheduled appointments for today. So there is also a possibility to show how this works on Android. If you give me just 1 second here, I can pull up a separate video for that. So if we were to create a new case on Android, it follows a very similar process as what we just saw earlier. I think you can see the screen, right? Could someone please verify for me?
Yes.
Okay, so as long as you can see this Android screen moving. Good, so, so we select the new registration date. We select all the attributes for this person, and it works very much the same way as in the web version. So entering the date of birth is mandatory field and the most important. Also the sex of the child. And then the primary contact's first name and last name. So then we proceed to the next phase. So we can enter the birth details and then also the immunization phases, but just for demonstration, I'll just show some of these drop downs as well as this immunization yes, no boxes that are available here. So that's it for this, for the Android demo just now, but I'd be happy to go into more detail about what's available on the Android application as well. But quickly, I just want to show off some of the dashboards that are available. And I think it's actually probably easier if I just show that live. So let me just stop sharing really quickly and then share a different screen here. Okay. So I just wanted to show the different dashboards that are available for end users to see, and start with the overall rollouts. This is the sort of overall view of how is the rollout of the EIR going in your context. So you can see, just based on the dummy data that we have here, the total number of children that were reached by the system. That's the number of new enrollments into the system in DHIS2 speak. Also the total number of doses that have been administered. And we can also see some charts based on the total number of doses or children. This is a first introduction to the cohort type indicators. But if we wanted to look at all of the children who have passed 1.5 years of age in the system currently, as within the last 12 months, they passed 18 months of age, how many of them actually received the full allotment of immunizations that they should receive? And so we're actually just at 6% right now. It's a headline figure. But it would also be interesting to see at what age these children are actually being reached by the electronic immunization register. So for example, the age at enrollment in weeks, and then also the age at the visit in weeks. So you should see some more follow-up in this 65 weeks or 10 to 13 weeks range, as well as these infants accumulate more visits and more doses. And then finally, location of immunization service delivery. We have some geographic information. This is the Laos org unit hierarchy we're working with here, as well as from our breakdown of the location of visits. You can actually see that most of them are from mass campaigns in our system here. Same goes for contraindications. This would be very useful to see what are the reasons why children are not being vaccinated, just in general, and also see some trends here. So guardian refusal and contraindication type. So that was the overall rollout. I want to do a couple more, one more basic one, and then we can go into some of the cohort indicators. So here we see the vaccination doses that were just given over the last 12 months, just a total raw count of the different dose types that were given. And now we'll go into age ranges, which are again, these cohort type indicators. So with this number of districts, is a bit hard to see, but this is actually by district, the number of infants with all required 0 to 6 week doses in the last 6 months. So of all those infants who crossed the 6-week threshold in the previous 3 months, how many of them actually received all of the required doses for that period? And so now you can make a sort of assessment of the performance of different districts based on some longitudinal data analysis. Do the same thing for the other windows of immunizations, such as 0 to 10 weeks, 14 weeks, and 0 to 9 months, and 0 to 15 months, etc.
So Brian, just to clarify,
Yeah.
those children are just the children that have been inside the tracker program.
Right, that's correct. So we're not looking at any other aggregate data, such as like population counts of the number of infants that are under 6 weeks within the catchment areas that are sort of not counted by the EIR, but it's just all of those infants that have been enrolled within the tracker. How many of them did you follow up to receive all of their doses, right? So when we do go to the last one on dropout rates, this is actually one way of representing the value of having longitudinal data as opposed to raw counts of the different doses. So in traditional dropout rates, you might just count the raw number of DPT1 doses minus the number of DPT3 doses, and then divide that by the number of DPT1 doses given to get your DPT dropout rate. The problem with this is that you're actually using inconsistent cohorts because based on the period that these doses were given and that you're using, the DPT1 doses and DPT3 doses would have been provided to different children. But now you can actually use consistent cohorts to make sure that this DPT1 and DPT3 were provided to the same individuals. And so we are actually just looking at all children who have passed 6 months of age this period, who have DPT1 but not DPT3, divided by everyone who has DPT1 and also passed 6 months at this age. So that's one explanation. We can also go into BCG, MCV dropout rate, et cetera. The final thing that I also wanted to show just in this quick demo was going into the system notifications. Oh, shoot, I think this is because it's the demo system. I actually need to be as a different super user to see it, but you can also show having the messages for birth notification sent to your admin user. So we can see earlier that a birth notification was sent to CRVS for Gilbert Sullivan. And the same after the birth certificate was delivered for Gilbert Sullivan. So that's all I have, but I'm happy to take questions or pass it on to Etam now.
Thank you so much, Kim and Brian. Thank you, Ian. This has been like a super thorough and super interesting demonstration and in general presentation of the program. If you still have questions, comments, and such, please continue posting everything in the thread of the community of practice, and Kim and Brian will be there answering your doubts or just curiosities. I will just give a quick mention of the Vital Events notification program, just because between Kim and Brian, you've heard mention it quite often. And yeah, so we published also a package for that. And the main role of this package, of course, has been to increase the availability, but also the reliability of data, to expand the coverage of core events, such, for example, stillbirth, births, and deaths, but there can also other information that can be reported, and they can trigger real-time notifications either via email, in-system notifications, SMSs, directly, if implemented as so, directly from the point of care. And then, of course, it's also can be used to improve the foundation of some more reliable demographic data and in general statistical repository of the target population. The way that the tracker has been designed and implemented, it's to have three main stages. That is the enrollment, which is the general enrollment of the vital events. So you just give like the personal information of the individual that is being enrolled. Then there is a stage that has to be selected. So depending on the actual vital event that is happening, so either birth, stillbirth, or a death, it's gonna show a different secondary stage. And then the final stage, if we can call it so, that it's the notification that can be either sent to the civil registration or can be sent, as I said, in system, out of system, via emails, also to the person that is the primary contact of the individual that has been inserted in the system. And all this information, of course, can be used for data analysis. We can provide as usual, the predefined dashboards. There can be some possibility of data triangulation. There is the possibility to have some line lists created in order to manage well the information that has been entered. In particular, for data triangulation, we would like to highlight that, of course, if you have in your instance more than one package, there can be some information that can be compared in order to get more information on the vital events that are happening. So, for example, the AFI tracker, once the national level program stage has been completed, there is one option that it's the outcome of the AFI case. And if, for example, that information is that the patient has died, this can be a triangulation that's you can triangulate it with the information that you can provide for the vital events and ask, for example, if the person has been notified of the death. Same thing can happen with as we said, the electronic immunization register, with COVID surveillance, with the case surveillance for TB. So whenever you have in any of the tracker information that are regarding vital events, these can be triangulated with the vital events tracker. Of course, very important to highlight, these can also be integrated with known DHIS systems as needed. But most importantly, especially because of this information, I would like to pass the word to Adolphe, who's going to give us a more realistic and hands-on overview of the implementation and the way that it happened in Rwanda, both for the Electronic Immunization Registry and the vital events. So Adolphe, to you.
Okay, thank you very much. Good afternoon to everyone. As Victoria said, I'm going to take you through or share with you the experience of Rwanda use case on how we have implemented the electronic immunization registry in the country and be able to make it interoperable with the civil registration and vital statistics systems of the country. So as you are aware, the global immunization registry package has in it, apart from the immunization registry, it has also a birth registration and also birth registration and also vital statistics information in it. But in Rwanda, while trying to implement the module, of course, we did an assessment trying to find what is existing. In terms of systems, in terms of information needed. So after that one, we have realized that the government was in a plan of implementing part of the immunization registry packages, namely the birth registration and death registration. So we, by then, that has been a little bit changed the plan on how we deploy the module in the country. So with these few slides, I'm going to try to summarize the Rwanda journey implementing this. Next, please. So the health sector in Rwanda is not really big, as the country size is also not big. So it has around 500 500 health centers and 48 district hospitals. Among of them are public owned, and also others are private owned. So DHIS implemented started in 2012, whereby by then the government or the Ministry of Health were mainly looking at a tool that can replace the existing standard application for the routine health information system. So gradually, other vertical programs started joining the process. So the government started integrating program-related systems, and that's when that's how also the immunization registry just comes in. So as of now, the immunization registry in the country is deployed across in all health facilities, public and private, and the SOPs for routine data management has been developed since the implementation has been there for a while. However, for the case-based reporting, the SOPs haven't been finalized to to support a number of implementations that has been deployed so far, namely the ETB registry, the HIV registry, NCD registries for NCD screening, and also this recent one for immunization registry. So for this immunization registry, the country on annual basis is targeting almost 370,000 children per annum to be vaccinated throughout the routine immunization schedule. Next, please. So this is a little bit a quick summary of what I have explained in the previous slide. So the immunization registry actually started in September 2019. That's when we, in collaboration with the EPI program, we, of course, with the UNICEF, UIO, WHO, and other partners, we deployed the immunization tracker in the country. But the customization started a little bit in May, but the rollout in the country and the training has been completed in August, and the system rolled out in September 2019. Next, please. So initially, the agenda to adopt or to roll out this plan. So as from May 2019, that's when the customization actually started. By then, we were targeting to have the immunization tracker implemented, have birth notification tracker, and adverse event following immunization included, and also have some TOTs for national facilitators, and also to support the rollout and the implementation, and have also end user training, because there were an agency to migrate from the existing aggregate reporting form, whereby data were being reported through HMIS routine reporting systems, and the program wanted to have a separate immunization tracker to maximize, to ensure that there is a full coverage of every child born in the country, to make sure that is access the immunization services. So as phase 2, the plan was to, of course, after rolling out the tracker, the plan was to focus on information use and dashboards configuration. And because starting, we didn't want to bring every modules at once. So then the IFI was planned as in the next phase, doing also adding also some vaccination logistics and stock management tools, because by then the program were using an Excel-based tool for stock and logistics management. So as I previously explained, we in the phase 2, the plan was to make the EP tracker interoperable with the government system for civil registration and the vital statistics system, so that we explored the unique identifier provided by this CRV system into the EPI tracker. As you know, in most of these developing countries, every newborn don't have an ID, and there weren't any identification number unique identification number for every newborn. So making the API tracker interoperable with the CRVS was to benefit from the unique identifier provided by the CRVS system. And then later on, of course, as you implement the system, it's not a static system. There might be some changes. There might be some cleaning of data, and also focus on data analysis. So in phase 3 of this journey, it was to also to finally focus on capacity transfer, because this system has been implemented as I mentioned, with support of DHIS2 Rwanda and other partners, namely University of Oslo and WHO and UNICEF and others. So we wanted to close the project by transferring capacity, documenting and doing some publications on this implementation, and also continue some post-implementation support. Next, please. So the AP tracker has then been deployed, borrowing leave from the global package, because as I mentioned, the country had already some immunization data, case-based data, but also part of it related to birth registration and so forth in another system. So we wanted to, we started by customizing the module, readapting to the Rwanda context, trying to make sure that it is aligned to vaccination schedule in the country. We did some trainings, of course, and planned some, and also did rollouts of the system across the country in all health facilities. Here I would precise that the vaccination points in Rwanda is being done at the health facility and also in some selected private institutions. And all of those health facilities are required to, on every vaccinated child and every newborn in the setting is immediately has to leave the facility after receiving the first dose of vaccines as required by the vaccination schedule in the country. The interoperability works, as I previously mentioned, was also necessary to make sure that the unique identifier from the national population, the national population registry is fetched, so that we ensure that the program knows that every newborn is vaccinated and know that those who missed out the vaccines and so forth. And also the other step was to look at data use for action. Here focusing on analyzing data to see the coverage and so forth. Here I would mention that despite all these listed steps that we're supposed to go through, we didn't actually go through them all, because there's multiple constraints just comes in, because as you've seen, we started in September 2019, and in March 2020, that's when we had the outbreak of COVID, and which has a little bit slowed down most of the planned activities. Next, please. So as I mentioned, talking about the the immunization tracker means that we are targeting every newborn. So to maximize that there is a full coverage, the interoperability was the right option to ensure that every newborn notified in the CRV system can be, the program can know that child has received the vaccine or is under the vaccination schedule in the country. So the CRV system that has been in place was mainly there to help multiple DHIS-based system. Here, name, I can say the cause of this DHIS module that has been implemented and is now interoperable with the civil registration system, and the verbal autopsy DHIS module that is also implemented in Rwanda, and it's fetching the cause of this from the civil registration. As you can see, the civil registration system, among the other vital events or the civil events, there is birth, there's death, there's marriage, there is divorce, there is adoption, and so forth. So all those civil registration events are all captured in this CRVS system. It's a national system that is rolled out. Very soon I'm going to show you how it works. So when the registration in the civil registration in the country is at even though it has recently started, it's now at over the 90% coverage, because the registration has been now decentralized to health facility for the birth that happened, the health facility, and also for the nearby cell office for the for the community birth. Next, please. Yeah, I think I have updated. Is this the last PowerPoint?
One online, so yes.
Okay. Let's see. Yeah, I think I have added some two slides for this on CRVS to explain a little bit how the CRVS works. If you can refresh a little bit or allow me to present those two slides.
I'm stopping sharing. You share.
Okay. So do you see my screen?
Yes.
I'm not sure if it's let me.
On the top right.
Yeah, so this slide explain how the civil legislation is done in Rwanda for the facility births. So you can see from your left, you see a birth happens in the maternity ward somewhere in the health facility. So the birth notification has been decentralized to health facilities officials to immediately notify a new birth. So this automatically helps. You see, they notify into the system, into the CRVS system, the new birth. Automatically, the CRVS provide a national identification number through the CRVS system. So if you look here, I'm not sure if you see my pointer here, for the health facilities officials to, after registering, notifying the child. So for the child to be registered, the civil registrar at the sector. The sector is the lowest administrative level of the country. The civil registrar actually accepts the notification. When the notification is accepted, this automatically that child is registered and be able to get the national, what they call the NIN, the National Information Number. So this information number is actually served for two things. So the NIN is automatically generated by the CRVS, which is automatically fetched by the DHIS, if you see on top left, into the DHIS to identify every newborn in the DHIS instance, which is Here we're talking about the AP tracker. So the interoperability for the DHIS to, for the CRVS to DHIS has been complete so far for birth registry and death registry, and also community death. But the process are being done to be also done for the immunization registry, because the program has been took a little bit time because it's going to affect the way the business processes at the vaccination points. So when the child is registered, after getting registered by a civil registrar, the child can easily have access to the birth registration certificate. Where you see there is Irembo, this is the e-government services portal where every citizen can go with the NIN and some credentials given to the person to automatically download the birth registration or this certificates and so forth. This is for the case of birth that happens in the health facility. So with regards to birth that happens in the community, for the child to be vaccinated or to be brought to the health facility for vaccination, of course, through the community health workers, the mother and the child are brought to any nearby civil registrar. This is the sector office, for registration. So this civil registrar will notify a child and also register a child. After registration, the mother can go back with the NIN. So this NIN can be shared to the health facility when the child is being brought to the health facility for vaccination services. Of course, the civil registration does everything through the civil registration system, which is automatically connected to the National Population Registry, where all birth records are automatically being pushed. And the civil registration, maybe these ones provide a little bit more information on who other beneficiaries of this civil registration database, namely the National Institute of Statistics for birth-related information. And of course, whether born from the health facility or being born in the community, after registration, parents can go to Irembo. This is e-government services. They can automatically generate or download the birth certificate, of course, which has a national identification number. So this CRVS comes in here to address the constraints, because initially the National Population Registry had population from age of 16 upwards. So there were a gap of under 16 of not having the unique identifiers. So the CRVS is also coming to solve the issue of under 16 people or children without the unique identifiers. So the NIN is being provided to the child, and it becomes a unique identifier across all services being given to the child until the child gets to 16. So because it is at its early stage, it's not yet clear yet whether this NIN is going to become the national ID number, or whether the person will get a new number for ID. In the chat, I'm not sure if there are questions to me, probably not. So that's how the community, that's how the civil registrations are being done, and data information are being shared across to the DHIS instances of the Ministry of Health, especially focusing on birth records. And this helps to have like to have a population data when it comes to calculate coverage indicators, namely for vaccination, for nutrition, and other services reserved for maternal and child health. So so coming back to the AP registry, the immunization schedule in Rwanda, a child at birth is being given BCG, and after so the schedule is, so at birth a child can have a BCG or polio vaccine. So this is the schedule. So you can so this is the schedule for vaccination for at birth for 6 weeks, 10 weeks, 14 weeks. So and there are a list of antigens being given to the child for every visit. So the immunization tracker in Rwanda has been customized based on this vaccination schedule, whereby we have the profile information and also the vaccination stage, which is more repeatable and captures information depending on the age at administration. So this is a little bit a screenshot of the last recorded cases for this Mareva Health Centers. This is date of this August. So the vaccination is not done on every day. That's for one of some of the reasons to make sure that there are no vials, there are no wastage for open vials or especially for open vials where they vaccinate children and maybe they fail to get enough children to vaccinate. They find some of the doses are wasted. So this is like a screenshot of the last the recent work list or vaccination list of this health facility. And for you, this is also some screenshots from the system, the recent one took yesterday on children, on immunized children. This is like a dashboard. So I think since we have developed this immunization tracker, as I mentioned, just COVID came in March, so the program didn't have much time to work with HIS to fully finalize the dashboards and work out on most of the program indicators and most of the other indicators, and also focus on data use. So those are the activities that are still in the plan. Mainly what those was in phase 2 as previously explained, and also phase 3, most of the activities has not been covered. Implementing this AP tracker is not a straightforward process. Of course, you build on what is existing, and also you look at the possible opportunities in place and build on those ones. So here I try to list some of the strengths of the opportunities that I can share with the audience. First of all, there were a program, the AP program, where to migrate from the aggregate to this case-based reporting. That is a very key when you want to deploy any case-based reporting. So there has to be the readiness of the beneficiaries has to be very high. We also, as you've seen, Rwanda has been implementing DHIS since 2012. So there are already a well-structured staffing from the nationwide to facility. So the facilities have data managers and in charge of vaccination in every health facility. And the good thing, all these staffs are on the government payroll. So which means if you train people, despite free movement of staff, but you have a quite number of stable staff supporting the rollout and also system use. The country from the health facilities, upwards, all health facilities are equipped with laptops, and most of them have, if I can say, 4G antenna for a very good speed of internet for data management. Where the 4G internet connection is not there, they have modems. So because the internet coverage in the country is over 90%, so you find most of these facilities are well connected on internet and have electricity. Implementing this AP tracker, sometimes the program runs outreach programs, and moving around with laptops is okay, but if you have tablets, which they do have a very good, they can keep power for a long time. So the tablets, the government funded the purchase of tablets and monthly airtimes for the in charge of vaccination in health facilities. This is also a very good opportunity to support this rollout. And the AP program was really very enthusiastic to be fully digitalized, as they have a feeling that implementing this digitalization, this tool will reduce the running and the printing cost of the vaccination cards, and also the running cost of this program. And also the use of tablets in outreach interventions, it was also a favoring, was also seen as an opportunity to make sure that every vaccinated child is automatically registered, is directly registered into the system. And at the end of the day, the synchronization can be done. And at the nationwide, we can know how many children has been vaccinated across the country. Of course, we had some challenges, because even though this module has been customized and reviewed by so many experts, the tool is designed as a general module to serve everyone. So that has to be contextualized to every country context. So it's not a plug and play tool. So it has to be readapted to the context, and sometimes sometimes you need to accommodate what is existing. So we found there is some existing AP system, and that has to be imported. And also by then the government has already, before having this global module, the AP program has itself started thinking of having a tracker module. So by then, a module has been there. Also, it has to be enhanced and improved. And also, but as you understand, you don't replace, you actually integrate. Of course, the other challenge it was to, while deploying this e-tracker, you find the technology asks you to add some of the new that information, namely the vaccination, namely the ID, namely the phone number, and you find on the existing vaccination cards in the registry, there are no columns or fields reserved to those information that are very key for the immunization, for the e-tracker, especially phone number whereby the notification has to be sent to remind or to thanks the mothers who brought their child for vaccination. Of course, implementing a system with a multiple stage, there are data completeness issues whereby sometimes people forget to update or to create new stages, to update new visits. So that contributes to data completeness issues. Also, by COVID-19, wasn't really favoring the mentorship supervision. As you understand, the COVID just came in while the system was at its early stage. So whereby people were needed to have active mentorship, supervision, and a close follow-up. So it couldn't happen because people were in lockdowns and so forth. And also some planned activities were not completed because of lockdowns. And of course, as HISP, we've been supporting the program, but the program itself didn't have a well-dedicated staff to respond to end users' requests as you are for any troubleshooting, any technical assistance that is needed. That's what I can say for now as Rwanda experience. It's time for, if we still have time, we can have some few questions, and that's it. Thank you.
Thank you so much, Adolf. This is always super important to have an overview of how things really happen once the packages are out there, I would say. We actually still have a few minutes that we're online. So I don't know, Kim or Brian, is there any questions that you think it would be worth it to share a little bit more with the general public while we're still live?
I was just looking at some of the questions from the COP. It looks like one question that was for Adolf. The question was, just one second. Does the tracker implementation in Rwanda integrate with the RHIE shared client record, for example? And also, can you talk a little bit about adverse event monitoring? Adolf, maybe you can answer that.
Yes. Okay. Thank you, Kim. Yeah, the immunization tracker, it doesn't integrate with the you mentioned the health information exchange. This is what we are talking about, right? Hello?
Yes.
Hello, Kim, are you talking about the
sorry.
health?
The RHIE, shared client record.
Yes, in Rwanda, we haven't yet implemented the shared health records. So all the information that is currently shared across all health-related systems are this information from the National Population Registry, especially for case-based reporting systems. So that's, I can say, is currently shared across whether health-related systems and also government services-related systems. But for shared health records, that's not yet implemented.
And anything about adverse events?
Adverse events, no, not yet. It's in the plan, but as I mentioned, COVID has paralyzed everything. So we most program is much more focused on COVID vaccinations. But before then, it was already locked down, so we couldn't introduce new interventions. So we're actually maintaining what has been implemented.
Great, and Adolfo, I just want to say thank you again from our side. It's been a great opportunity to work with Rwanda on this immunization program and birth registration. Rwanda is an interesting use case because your CRVS system is so advanced and highly functioning. It was an interesting process to see kind of the opportunities for the CRVS system to go into DHIS2 versus DHIS2 pushing information to the CRV, basic information to the CRVS. So I think that has been a very interesting use case, and also the ability, since you have such a high vaccine program, to be able to use information from the CRVS system as an M&E tool. And then also to see the work that you've done with the immunization package and getting it working on the ground has been quite impressive. You're right, it's not a plug and play, and I think you and team have done a great job having these high-level conversations on deciding what is the Rwanda context and how do you want to integrate that, what works for Rwanda. From my point of view, I will say there's multiple ways to do adverse event monitoring. I remember 2 years ago when we went to Rwanda, there was one data element that said, you know, has the child had an adverse event in the last 30 minutes, which I'm sure we're all used to now with the COVID context. And then you had an option to trigger some response. I will say that we have published from UIO on our website an adverse events program that you can look into. A lot of this information can be found on DHIS2.org immunizations. I'll go ahead and turn the time back over to Victoria.
Thank you so much, Adolfo, and Kim, also for wrapping up these. It is indeed like super important as well to highlight. I would like to wrap up this webinar, reminding everyone that with this new format, the thread will remain open, and you can continue posting questions, especially to Adolphe, or about general questions of the programs to Kim, Brian, and Andy, of course. So even if tomorrow you come up with a question, please feel free to continue dropping questions, doubts, comments. We continue answering them in the thread. And talking about comments, you also find a comment about a registration to a webinar that is about BNA, scorecards, and other apps. So feel free to register to that one as well. And a reminder that we will continue to offer these immunization webinars in English, of course, and in French. And the one about this same topic in French will be tomorrow. Just a reminder in case you want to forward the information to your French colleagues. And yes, I think this is a wrap up. Thank you so much, everyone. The presenters, it's been fantastic to see the amount of work that has been produced, and everyone who showed up to listen to us and our presentations and case for Rwanda. Have a lovely day and evening, depending on where you are, and yes, feel free to continue the thread whenever you want. Cheers. Bye.
Okay. Bye.
Bye.